this is official welcome to all of you for the weekly huddle. I'm going to mute all of you and then we'll unmute whenever you have to speak something so that we can reduce the crosstalk. My name is Anup Agrawal. All the attendees here pretty much know me. I'm hosting this session for the 21st time. And with me is my co-host, Praneeth. We both are cardiologists at Care Banjara. And today we are going to discuss on peripartum cardiomyopathy. And for that, I have a group of experts who can tell us about how to go with this. We have esteemed gynecologist. I can't say her more. As I'm reading about her, I realize that I can't just finish describing her qualifications on this. Dr. Manjula Anagani is here. She's a Padma Shri recipient and she is a consultant at Medicover. We have Professor P. Krishnam Raju. All of you know him. He is a very senior cardiologist at Care Hospital. And then we have got Dr. Raghu. He heads the non-invasive lab at Care Hospital. He's a cardiologist, of course, and he's a president-elect for Indian Association of Echocardiography. So as you all know, and people who are joining the weekly huddle for the first time, this is a casual interaction which revolves around one particular case. We take one topic, we take one case, and we discuss about it. While we are interested in understanding the science and guidelines and everything, we are really focused on practice patterns. The main goal of weekly huddle is to understand what kind of decisions you are taking, why are you taking that decision, and to understand your thought process a little bit so that we can put it in our own clinical practice and share thoughts. I'm going to also introduce a few people in the group. We have Dr. Chandramukhi. She's also a cardiologist at Care Hospitals. We have got few residents from Care. Dr. Praveen, he's an assistant professor of cardiology at Osmania General Hospital. And we have got Vrinda. She's an endocrinologist at Care Hospital.
Yes.
And Dr. Vrinda is my wife, so that's conflict of interest. So typically, the way I start this session is I give a clinical question to Praneeth. We get Praneeth's input, and then I open the session for audience interaction. Because we have few experts here, what I will do is I will ask other people to share their opinion, and then we will go to our guests for tonight to see how they would do. So Praneeth, here is the clinical scenario. This patient I saw a few months ago. This was pre-COVID time. And please let me know if you need any more clinical information than what I'm providing. She is a 29-year-old female. She does not have any known medical issue. She is postpartum day 4. This was her first pregnancy, which was spontaneously conceived. And she had a normal vaginal delivery without any complications. She gave birth to a baby girl. On day 2 postpartum at home, she started complaining of some dyspnea. No chest pain, no other symptom, just some dyspnea. She discussed with her gynecologist. On day 3 postpartum, she underwent an echocardiogram which showed LV dysfunction. And at that time, she was instructed to come to a cardiac center. So on day 4, she was in the emergency room at Care Hospital, and I'm talking to her. This was her presenting complaint. Other than dyspnea, really nothing else. When I saw her, her blood pressure was 130/90, heart rate was 112. On examination, she had clear evidence of fluid overload. She had elevated JVD. Crepitations were present bilaterally. She was a little bit desaturating, 88 on room air. On oxygen, she was maintaining 98%. She was normothermic. Her ECG had sinus tachycardia with no ischemia otherwise. Echocardiogram that was done at bedside showed LV ejection fraction about 35 to 40% with global hypokinesis. No real LV dilatation that I could appreciate. Very mild mitral regurgitation. Right ventricular function was okay. IVC was dilated. We got some labs later on. The pertinent labs are hemoglobin 10.5, creatinine 0.8. Electrolytes are okay. I tried to probe a little bit about family history and her previous history, and really I couldn't get anything contributory. Otherwise, she has 2 siblings, both of them are fine, no real family history of cardiomyopathy or anything of that sort. So I'm going to obviously manage her with typical heart failure medication, namely diuretics, oxygen support, salt restriction, fluid restriction, and maybe give her a little bit of nitroglycerin to get her preload down, and later on start her on a little bit of beta blocker and whatnot. The question for you, Praneeth, is other than traditional heart failure medication, what else would you do? Give us some input about how you would approach this, particularly emphasizing on role of bromocriptine here or role of cabergoline here, or if you would manage it slightly differently. Praneeth, on to you.
Yeah, no. Regarding this case, I don't have much to add with from whatever you have said. So essentially, my management also will be on diuretics, fluid, salt restriction, and all the regular heart failure management stuff. Regarding the usage of bromocriptine, pergolene, and other drugs, I have zero experience. I have zero knowledge on how do we do and how do we add and all those things. So I'm keen on learning. If I have to use, how do I use them? So nothing more that I can add to whatever that you are managing.
So, Praneeth, the reason why I wanted to ask this question is, and this is open for anybody else to answer. This patient, I have an empiric diagnosis of postpartum cardiomyopathy because there is really no other reason why she would have that cardiac dysfunction. By the way, I also should add, her pregnancy otherwise was non-complicated in terms of that she did not have eclampsia or pre-eclampsia or anything like that.
Yeah.
So is there any difference in how you approach a heart failure related to postpartum cardiomyopathy versus a heart failure in a typical dilated cardiomyopathy? Do you approach it any differently?
No. So the acute management more or less will be the same thing. But the only hope or only thing that I probably would be hoping is that probably these patients may have a chance of getting better with some time versus someone who has a dilated cardiomyopathy. I know that it's a long journey. That is the only thing that I look at these patients differently. But other than that, from the management point of view, probably nothing more that I can add.
Okay. Anybody else has anything to add before we get to our guests for tonight? Anyone who would do things differently or has a different thought? Maybe I'll pick a couple of names. Krishnam Raju sir, I'll get to you because I think once you share your opinion, then nobody else will share their opinion. So I will get to you in a second. Dr. Chandramukhi, could I have your opinion in terms of how you would manage these cases? I'm unmuting you.
Yeah, acute heart failure, I will manage in the same way as you did. And I also don't have much experience with the bromocriptine, but I have listened from various people in our hospital that bromocriptine is helpful in these cases of peripartum cardiomyopathy.
Okay, let
And
me. Yeah. Sorry, go ahead, ma'am.
yeah, that's it. That's it. That's it.
Okay. Dr. Praveen, anything else that you want to add? I'm unmuting you.
Sir, regarding the acute failure management, the same line as you have said, sir, I have zero knowledge regarding the bromocriptine usage.
Krishnam Raju, sir, your opinion on this?
Okay. See, the nomenclature itself has been somewhat debated because at a given point in time, like in your patient, we don't really know whether it is partum cardiomyopathy, peripartum cardiomyopathy, or had always been present even earlier, worsened now. So one of the suggestions by the world experts had been to rename this entity as pregnancy associated cardiomyopathy. So, which basically means your patient may have had cardiomyopathy even earlier, it became clinical now, that is one. Two, 10% of the so-called peripartum cardiomyopathies come in the last 1 month of pregnancy. Third group are those who come after the delivery up to anything like 5 months. Now, there is an interesting question here. Why 5 months? Why not 5 months or 6 days, let us say? I will answer that a little later. And then the fourth category is those people who had peripartum cardiomyopathy in the previous pregnancies and has recurred now. Another category will be peripartum cardiomyopathy now continuing as non-regressive continuing cardiomyopathy. So there are multiple subtypes. There is another way of looking at it from a different European group. They said mainly there are two types of peripartum cardiomyopathies. One is inflammatory type, which could be assessed by doing a myocardial biopsy and some other investigations, which if there is time, I will enlarge on that. And then two, non-inflammatory peripartum cardiomyopathy. It appears that inflammatory cardiomyopathy is worse than non-inflammatory cardiomyopathy for various reasons. That is my first take on that. Going back to what Praneeth and Chandramukhi has talked about, and you also questioned specifically about bromocriptine, I had used it in some patients, but of late, the entity of peripartum cardiomyopathy itself is not as high as we used to see, say something like 10-15 years back when I was working in Usmania General Hospital. There we had a lot of them, but here in a private setup we don't see. I don't know whether it is related to economic status or a better nutritional status or better demographics, or it has really come down. We don't really know because it varies from country to country, region to region. That maybe we'll go back to later. So as far as bromocriptine is concerned, this is because of certain genetic abnormalities in the woman. They have a deletion of what is called STAT3. Don't ask me what it is because I won't be able to answer you. So this deletion of STAT3 leads to, during pregnancy, an increased release of what is called cathepsin D. Cathepsin D. Now, this cathepsin D is the real villain. This is the one which cleaves the molecule of prolactin produced by the pituitary gland during the last months of pregnancy and 5 to 6 months post-delivery. So this cleaved prolactin releases a molecule called 16 kilodalton A, 16kD small a. This is a microRNA. This releases a microRNA 146. This microRNA enters the myocardial cells. Then this is anti-angiogenic and it is apoptotic and inflammatory in nature, thereby killing the cardiomyocytes. And this produces exosomes. These exosomes enter the myocytes and destroy the myocytes. Now, bromocriptine is expected to block this chain of events. And it has been shown that the evolution of the peripartum cardiomyopathy is very closely related to the levels and timing of release of prolactin. Initially there is not much of prolactin. As the pregnancy goes into last month, it increases. Then lactation. During the lactation period, prolactin is again high. That is the reason why in these patients, breastfeeding is to be avoided by some advocates. So here, the bromocriptine may be able to block this cleavage of the prolactin, thereby avoiding the death of the cardiomyocytes, thereby avoiding the cardiomyopathy related to the pregnancy. The first report came from Germany and just 10 patients and 10 normals. That is the comparable study. That was the very first one which came in sometime in 2010 or something like that. After that, few more studies have cropped up and few groups have found it to be very moderately useful. Few groups could not prove it. But if you have exhausted your medical therapies, before you go on to invasive therapies and like LVAD or intra-aortic balloon, ICD, cardiac transplant, all of them are also options in a very sick pregnant woman. So before you do that, it is worthwhile trying something like bromocriptine. It could be effective. It could also be used as suggested by European Society, the recurring pregnancy to prevent recurrence of the postpartum cardiomyopathy in the subsequent pregnancies. But we don't really know, nobody really knows how effective it is, because not every woman will have a recurrence of postpartum cardiomyopathy. Roughly, it is about 50 to 60%. That will come to a little later on. So, but it is advised as a preventive therapy in the subsequent pregnancies. That is the role of bromocriptine. When you use it, and when I used it according to European data, 2.5 milligrams twice a day for 6 weeks. This basically means that this is after delivery, or if you have started it before delivery, you continue it post-delivery for a period of 6 to 8 weeks, and then maybe you can take it off and continue other medication. That is a specific role of bromocriptine. People also have used pentoxiphiline. Pentoxiphiline anti-inflammatory and also anticoagulant, and also it opens up the microcoronary circulation of the myocardium. So people have used pentoxiphiline, but I haven't really, except in peripheral arterial disease. I had not used it in this particular clinical setting. There are some groups who have used immunoglobulins, intravenous immunoglobulins, but there isn't any final word said on that. But probably, if you use immunoglobulins in a proven inflammatory myocarditis as the cause of peripartum cardiomyopathy, maybe it may have some role to play, but otherwise non-inflammatory cardiomyopathy, it is of no real use. Some people have used corticosteroids as well, but did not find it to be of any use. I think I completed my answer to your question, Nanu.
Yes, sir. Thank you so much. That was pretty comprehensive. And I do have follow-up questions, but I'll come back to you. Let me actually get Dr. Manjula's thought here. So Dr. Manjula, I have got 2 questions for you, and then you can share your thoughts about this particular case as well. Number 1 is, this is day 4 postpartum patient in emergency room. Right. I'm sure even before I get into this patient, an obstetrician has already been called in, a review has already been placed, and you are there at the patient's bedside. So what all value you can add, or if you can guide us towards the treatment, that is number 1. And number 2 is, could you have done something while she was pregnant itself to predict this, or can we be of any help in those kind of situations?
Right. Before going to this answer, I would like to give my opinion about what Sir has told and everything. See, first, when we look at the cause, now it is more and more coming out that it is the vascular hormonal hypothesis which is coming out. Like Sir said, hormonal part of it, it is because of the 16K Dalton thing which is coming out, that is abnormal prolactin. And the second thing which has been actually coming out very much, which is why people get confused between PRH and the Ppcm, is that it is a vascular endothelial growth factor which is actually blocked, either because of soluble FMS like tyrosine kinase or something like that. So this is the reason, the cause being the apoptosis of the muscle fiber and the vascular endothelial function which is happening, which is causing this. Bromocriptine has started in the first place. But the second reason why it has become more and more, and by obstetricians, we do use a lot of bromocriptine and cabergoline in these patients. In fact, if my patient comes to me postpartum with Ppcm, I would first put cabergoline for her, is that the efficiency, the afterload, how much she can take without being dyspneic and being able to feed the baby. So WHO says in the Western countries or anything where when the ejection fraction is less than 35%, the lactate breastfeeding should be avoided. So the drug of choice for suppression of breastfeeding would be cabergoline or bromocriptine. So with bromocriptine, sir has told you the dosage that is 2.5 milligram daily twice for 6 weeks. But with cabergoline, we start 0.5 milligram to start, then 1 BD for 2 days, then followed by weekly twice for 3 months, and then weekly once by 3 months if it is because of this cause. And like sir said, I think we usually try to, in the next pregnancy, give during delivery also. Now, here what I wanted to add is, in this particular case, on 4th day, you have seen a blood pressure of 130/90, right? Dr. Anup?
Yes, ma'am. Absolutely correct.
So
Yes,
130/90 within a week. See, it takes 1 week for the whole PIH changes in the body to come back. Sometimes postpartum hypertension also will come back to normal in 6 weeks. So if it is 130/90 postpartum, you should also look at coexistent PIH, even if the pregnancy was normal, because we have to go by the thing of systolic more than 30 and diastolic more than 15. That itself will hold true in this case. So in a case when a person comes with post-delivery pregnancy dyspnea, we always look at pulmonary embolism and PRH in this case, because 130/90. And there is also first in thought would always be to do a 2D echo, because to rule out both the pulmonary embolism part of it and the Ppcm part of it. But saying this, anything which can we predict? No, I think this is something which we cannot predict unless she presents with some symptoms antenatally, either in the form of dyspnea. But high degree of suspicion is very much needed, because the dyspnea, which is like air hunger, both are almost similar because of progesterone itself. So unless we suspect there is a PRH associated, since both the pathogenesis of the, apart from the prolactin, the vascular endothelial factor part of it is same when it comes to PRH and Ppcm, we should think in high degree of suspicion. That is first thing. But sir absolutely told correctly that in the recent times we have seen less and less of Ppcm, because the nutritional factor has come down drastically, in the sense that selenium deficiency has been associated with Ppcm and even abortions. So the supplements of selenium which we start giving, A to Z or even micronutrients, have decreased the incidence. And the second thing which has helped is, in the recent times, with the more and more knowledge about PIH, that is pregnancy-induced hypertension, we started adding L-arginine or anything which can increase the endothelial nitric oxide. So vascular dilatation, basically in the placental blood, and the lower resistance placental circulation is something which we are encouraging. So with that, the VEGF is actually getting better, and the outcomes both in the PIH and the Ppcms have come down. So these are the two reasons why we are seeing lesser and lesser peripartum cardiomyopathy. So I think either the PRH, if it has come postnatally in this particular lady, or whenever any lady with PRH comes, along with the antihypertensives, today's time, most of us have started L-arginine so that we can have an endothelial nitric oxide release and the placental circulation to be improved and the vascular endothelial growth factors to be functioning normally. So if this can be added, I think the incidence can come down. And I think that differential diagnosis, like everybody knows, when she comes to us in the ER, first thing we are worried about is, did we miss something which during antenatal periods or during delivery, or pulmonary embolism is always first on the highest list, but hemoglobin being 10.5, anemia is ruled out. And the third space enclosure, when you said pulmonary edema is there, it is the LVF which always comes in the first thing. So 2D echo is the way I would definitely go forward.
Ma'am, before I would let you go, just one more thing. You told about arginine. I don't think we have ever used arginine. Could you give us some idea? How do you start it? Yeah.
The L-arginine sachets are available, capsules are available. In antenatal period, we start off right from whenever there is a higher risk. Like previously, we used to start low molecular weight heparin or ASA before. Nowadays, lesser and lesser ASAs we have started using, loprins, and we started increasingly using L-arginine, because the knowledge have increased in showing us that L-arginine, when it acts at the level of endothelium, it releases the enos, endothelial nitric oxide. So because of that, there is a vasodilatory effect in the placental bed. So therefore, the IUGR is decreased, Liker has increased, the PIH, the effects of PIH is decreased. It per se does not decrease the incidence of PIH, but it pushes the PIH so that microvascular pathy, which we see in the placenta, is decreased. So we start using it right from at 13 weeks when we see the Dopplers. Nowadays, we do a pentamarker at 12 to 13 weeks, Dr. Anup, where we pick up PLGF, that is placental growth factor, which will predict us the incidence of the PIH later in the pregnancy, and the vascular resistance in the Dopplers. So these two put together will give us the risk of the PIH later, early onset and late onset also. So once we see that, we start allogeneic or embryo safe or whatever we want to label, whichever thing, along with zinc, right from 13 weeks, or when we start seeing the PRH after 28 weeks or anything, along with the lebetlol or whatever we are starting, or alpha dopa or Nicardia, we also add allogeneic because we need the circulation to be increased, because we know it is the microvasculopathy and the vascular resistance which is the cause in PRH. So we start off, it's 2 sachets per day till the delivery, and after that, depending on what we see.
And the selenium deficiency, ma'am, that you
Yes.
brought up, are these tablets A to Z and whatnot, are they sufficient to do that selenium deficiency?
There is a crablet capsule called Celase Fort for all the prenatal. In my practice, I really don't know how many are using it, but every woman coming to me for a prenatal advice, not prenatal, this thing would receive one folic acid definitely, with the B6 and B12 combination, that is Folsafel or Folsurel or anything like that. Then the second medicine I always add is Celase Fort, which is having all antioxidants with selenium. Because this started off with when I started practicing in care hospital itself, when I used to see recurrent pregnancy loss women coming to us, and then everything would be normal. How many hour tests we do, it would be normal, except that antithyroid antibodies will be positive, and the thyroid is also borderline. Then when I started researching more and more, then I came to know that selenium deficiency is more prominent in this hypothyroid people where antibodies are more. Whenever this is immunological theory comes up, selenium is the one thing which is deficient, and that is the reason for recurrent pregnancy loss in this women. So which started with my insight into the recurrent pregnancy loss because of hypothyroidism, helped me a lot in understanding the importance of selenium. So I give the patient Celase Fort every day once, 3 months prior when they come to us, and we continue for the first 3 months of pregnancy. So in our practice till now, luckily we did not see Ppcm in patients, but other patients who do come, incidence has definitely come down.
Thank you so much, ma'am. Let me get to Dr. Raghu. Sir, you heard all the stories. How would you approach these patients? And since Dr. Krishnam Raju brought up the inflammatory versus non-inflammatory PPCM, I'm going to ask you this question. Do you see any role of doing endomyocardial biopsy in patients who present like the one that I told you? And also your approach towards this patient? Dr. Raghu.
Yeah, I heard everything. I think the whole gamut of this very rare cardiomyopathy has been considered. The only thing that I would think about when a patient presents like that is after the initial management of heart failure. Generally, they respond to all the medications that you and Praneeth had stated. And once the heart failure is under control, you start dissecting out whether this can really be kept as a diagnosis of peripartum cardiomyopathy. So you try to exclude the various other causes like severe anemia. Patient probably had an undiagnosed preeclampsia with severe hypertension leading to LV dysfunction, which subsequent to the pregnancy manifests with a decrease in the LV ejection fraction, which is diagnosed subsequent to delivery. And of course, rule out thiamine deficiencies in these patients. I possibly, as a rule, give thiamine to all these patients. So those who are because of thiamine deficiency, very like cardiomyopathy, would have a reversal of the cardiomyopathy. Having done all that, I start worrying about what to address for the future. So this is where the importance of an inflammatory cardiomyopathy versus a genetic peripartum cardiomyopathy would possibly come in. A person with a myocarditis, if the prognosis would be worse, and if the patient really has a very severe LV ejection fraction, you start worrying about the need to sustain her, use LVAD, use ECMO, bring her out of the congestive heart failure till the myocarditis resolves. If you do not have any pointers to suggest that, and the patient is making a steady recovery, then you start worrying about what their future is going to be. So that can be addressed only during follow-up. If the LV function improves considerably, then it becomes much easier to manage. You would need to possibly keep them on the ACE inhibitors and beta blockers, at least for a period of 1 to 2 years. That is what is recommended in the guidelines. But the other important question that is often asked by my patients, I can say that I have seen about 10 to 15 patients in the last 10, 12 years. There has been a steady decrease in the number of cases, as Dr. Krishnam Raju mentioned. Incidentally, I'd like to point out here that whereas the literature mentions that there is a higher incidence in the African countries, there the incidence of peripartum cardiomyopathy is more in multiparous women rather than in primary or the second pregnancy. For all the patients I have seen, have been primary or after during the second pregnancy. I have not really seen peripartum cardiomyopathy in multiparous, so possibly also because I rarely ever see multiparous women in our country, as not as commonly as we do in the other countries. So having settled this, the next question that is to be addressed, which has not been talked about, is the recurrence. Normally there is supposed to be a recurrence of over 20%. So the patient inevitably asks you the question, how do I go in for another successful pregnancy? And the problem comes in when the patient is very keen to have another pregnancy, or if unfortunately the first pregnancy has resulted in the death of the child after birth. Then what do you tell the patient after? Of course, if the patient's ejection fraction remains bad, you categorically state that they cannot have a second pregnancy because the maternal mortality is very, very high. In fact, the maternal mortality in this condition is over a 5-year period is more than 50%, which is a little more than even the ordinary cardiomyopathies that we normally come across. So you certainly categorically state that you cannot have a second pregnancy if the ejection fraction is not improved. But if the ejection fraction is improved, then comes the problem as to whether to advise a second pregnancy. Usually I tell my patients that they should not, if they can help it, have a second pregnancy. But if something, if they insist on or they accidentally have it, I tell them that they need to be very closely monitored and that the recurrence rate is very, very high. And I would even go to the extent of suggesting an MTP if there's been an accidental pregnancy. This is where possibly genetic testing might help. So if those patients where you have excluded myocarditis and you do a genetic testing, and if the genetic testing does not keep the patient in a few of the genetically known brackets, then possibly the chances of recurrence may be a little lower. But that is something which is very foggy at the moment. It's very difficult to answer the question. Dr. Manjula made a mention of L-arginine. I have been using for quite some time carnitol, which is N-acetyl-carnitine. And you might ask, what is the basis for this? This is supposed to help in many of the myocarditis patients. There were, in fact, a series of articles in the mid and early 90s, which subsequently has been given up. But somehow I empirically use it. It's a drug that doesn't produce much harm. Whenever I think that there is a patient of possible myocarditis or a possible peripartum cardiomyopathy, tend to use it for 6 months. And in a few patients, there was some resolution, but as you know, it's very difficult to attribute this to the drug. You know very well that patients with this kind of presentation quite often improve on their own. They resolve spontaneously. So it's very difficult to just gives me some sense of comfort to give the medication. And I really don't know, there are not enough data, scientific data, to say that this is definitely evidence-based practice. I think I have covered whatever I needed to mention. Dr. Anup, if you have any questions on what I have addressed, I am willing to answer them.
Sure, we'll get you back. Dr. Radha, if I can just get your opinion about this nutritional deficiency business that we have for peripartum cardiomyopathy. There is a lot of thought process about zinc and selenium deficiency. It has been studied in various countries. Sure, India does not have the data, but do you have any insight on nutrition deficiency and cardiomyopathy peripartum and how we can help? Dr. Radha?
Yeah, just a minute.
Yes, ma'am.
It's a general thing that nutritional status is connected to the occurrence of cardiomyopathy. But as Manjula madam said, good evening, madam. I'm Radha. I hope you remember that I'm from Sunshine Hospital. Hey, okay.
Yeah.
Hello.
Sorry, I muted you, Manjula madam. Please go ahead now.
Yes, I remember. Please go ahead.
Yeah. So generally, yes, there is a link, as madam said, zinc and selenium is most important. Additional to that, vitamin B12 is another factor that we as dietitians look into. And we just don't prescribe the tablets, as madam said. Generally, what I do is, when the tablet is given and I know that there's a generalized malnutrition among these women, then I prefer to give an advice for IV. I don't know, madam has to give in input where something like salicil, which is a combination of zinc and selenium, a higher dose, and the absorption would be way too better than when you give it as a tablet, because there are so many inherent factors which inhibit the complete absorption or utilization of the tablet. So an IV will be better, but there's always been connection that malnutrition does have a role to play in the occurrence of cardiomyopathy.
Yes, Radha. But once we know that there is deficiency, so here to prevent, Dr. Anu, we start, like I said, we start 3 months prior only. When Dr. Raghu said about thiamine also, nowadays we get this folic acid, thiamine, B1, B6, B12, all combination capsule. Now
Yes.
India is famous for that. So we
Yes.
start one tablet right before even the pregnancy, and then continue into the with selenium and zinc, the thing. So I think that is the one way to go forward.
In such cases, madam, I still have this doubt. When you know that their general intake of food is bad or their general nutritional status is poor, do you think IV will be better than giving a tablet?
They are having hyperemesis or anything like that, when we see a lot of ketones and all, then only we go for IV. Otherwise, generally, unless there is a clear-cut deficiency noted, here we are giving empiric treatment as a preventive thing from prior. So it is the oral medication which we start 3 months even before they go into pregnancy. So but deficiency is definitely noted because of if they have any, like, Kernix is there, and then we evaluate and then see there is this deficiency, then start treatment like that. So otherwise, then it will be IV. But otherwise, it's mostly oral only, and the patient compliance also would be good when we started from 3 months before.
Okay.
Perfect. Thank you so much. Dr. Krishnam, Raju, your hand is up. I think you have something to add. And I would also invite you to shed some light on what kind of genetic testing we can do in these patients. Let's say this 29-year-old, because not just let's say, I will tell you the clinical story. So I did not start her on bromocriptine. I gave her just the routine heart failure medication. She was discharged after 3 days staying in the hospital. LV function is still about 40%, but clinically much better. So as I'm discharging her, is there something I can do? I can order some genetic test. Is something that is done in Hyderabad? Could you just help us and also share your input otherwise? Sir.
I have, I think, too much to talk about your questions. I don't know whether you would have that much of time, but let me just quickly go through.
Sure, sir.
One mode of treatment which has been omitted from discussion has been anticoagulant, like low molecular weight heparin. First, let me give my comments on other colleagues' discussions. Now, low molecular weight heparin is definitely indicated in these patients if they have echocardiographic LV thrombus or any intracardiac thrombus, or if they have already embolized, or if the ejection fraction is left less than 30%. So these are the patients where it is strongly recommended to be given low molecular weight heparin. That is one clarification which I wanted to add regarding treatment. Then I think Dr. Raghu was mentioning about African countries. The worst incidence of peripartum cardiomyopathy has been registered in Nigeria. Nigeria has 1% of their births with pregnancies with peripartum cardiomyopathy, and they researched and found very interesting things. So in Nigeria, it is the usual practice, like some other African countries, to feed the postpartum woman with solid lake salt, and then for 2 months after delivery, they are made to lie down not on a cotton bed, but on the bed of a mud. Mud contains a lot of sodium as well. So these are the two reasons, in addition to other nutritional factors which have been said to lead to a very high incidence of peripartum cardiomyopathy, Africa in general, Nigeria in particular. So these are the two comments on that. There are other questions, whether we can see, one of the most difficult tasks is to suspect peripartum cardiomyopathy. The reason being, all the symptoms of cardiomyopathy are all the same as the symptoms which are normally experienced by the pregnant woman. Make it chest pain, shortness of breath, palpitation, edema, jugular distension, third heart sound, fourth heart sound, murmurs, right? Some ECG changes. All of them are common to normal pregnancy and also cardiomyopathy. So it is indeed, it is not all that easy to make a diagnosis of peripartum cardiomyopathy based only on symptoms. It is near impossible. But there are certain things which can help us to differentiate them apart from echocardiography. Echocardiography is the heart of diagnosis in these matters. So keeping that aside, there are other things which we can do, like for example, you can suppose if an ECG shows a left bundle branch block, even without symptoms, these are the patients who are very, very likely to go into cardiomyopathy. Asymptomatic left bundle branch block during pregnancy. Then 2, if you take a blood sample and then assess the microRNAs, the number 146 microRNA measurable in the circulatory system is very, very highly suggestive of a cleaved prolactin, thereby indicating a possible peripartum cardiomyopathy. Then you also have certain new studies where they have shown that inflammatory markers, like for example troponin, NT-proBNP, and then tumor necrosis factor, etc., etc. So these also help us to strongly suspect a possible cardiomyopathy, and they also give a prognostic value. They also will tell us whether there is a possibility of a recurrence in the next subsequent pregnancies if they do occur. Then talking about the etiology, a lot of things have been said by Dr. Manjula and Raghu. One thing I can add, this was a very favorite hypothesis until many, say something like 2010, 2015. This was called as fetal shimmerism. Fetal cells travel across the placenta barrier into the mother, they circulate, then they settle down in various tissues of the mother, including the cardiomyocytes. And when they settle down there, they produce a immunological response and destroy the cardiomyocytes and produce postpartum cardiomyopathy. And interestingly, those who have these fetal cells in the maternal tissues are also prone to subsequent pregnancy cardiomyopathies, because these fetal cells continue to be present. During the challenge of the next pregnancy, they become active again and then damage the maternal cardiomyocytes. So this was what was called as the fetal shimmerism. This is not too much talked about in recent years, but this was a favorite hypothesis which a lot of people have written and talked about in 2010 to 2018 or so. Now the genetic testing, as I initially mentioned, if you can look for the deletion of STAT3 in the chromosome, this will give you an idea that this lady is going to have a high cathepsin D, which means that she is going to release this cardiotoxic 16 kilodalton A and produce an exosome which will get into the myocytes. So that is one test that can be done. But apart from that, there is nothing else. There was another question which cropped up during Raghu's discussion, whether we can predict future pregnancy, subsequent pregnancy, cardiomyopathy again. Now it is like this. At the end of, normally most of them recover by, see, the roughly 75% of postpartum cardiomyopathies recover reasonably well or completely in the first 1 month. And then it continues to improve up to 5 months. The original definition of peripartum cardiomyopathy came in 1971 by a doctor, who was that? Damakis, I think it is a German name, Damakis. So when he defined peripartum cardiomyopathy, he used that 1 month before a delivery and 5 months after delivery as the time band. So that continue to stick to our usage of the definition even now, but that is not entirely right, because a small number of patients do improve even in the 6th month. Even smaller number have a potential to improve partially or completely in 48 months. 48 months, but that is a small number. Now, how do you detect whether a particular lady is going to have a problem in the next pregnancy? One indicator is the ejection fraction. If the ejection fraction is less than 35%, 2/3 of them are likely to develop the recurrent peripartum cardiomyopathy. If the ejection fraction is something like 35 to say 45 or 40, the chances drop down to 30% plus minus. If the ejection fraction has improved to more than 55% after delivery, then at the end of 3 months, then the chances of recurrence are less than 20%, approximately around 18%. You give or take 2 to 3%. Then second way you can detect is doing an MRI, cardiac MRI. If you do a cardiac contrast MRI, if you detect gadolinium uptake in the myocardium, meaning thereby that there is myocardial scarring, so this is near certain that this lady is going to develop a recurrent postpartum cardiomyopathy. Now that MRIs are available everywhere, but the expertise in reading these cardiac MRIs is required. So that is the second indicator. Third indicator is the dobutamine echo or exercise echocardiography. So if you do a dobutamine echocardiography or exercise echocardiography and then test the myocardial reserve capacity, myocardial contractile reserve capacity, which basically means rest ejection fraction and then peak exercise ejection fraction. If it is more than 5% from rest to peak exercise, the contractile reserve is reasonably good. So if the contractile reserve is reasonably good, the subsequent pregnancy cardiomyopathy, the chances are significantly less. Even if it occurs, it will be a low risk peripartum cardiomyopathy. So the exercise echocardiography, either pharmacological or physical exercise, can give us some insight. Not that it is 100% reliable, but it is reasonably useful. The other thing that has been talked about is inflammatory markers. At the end of 3 months, if your NT-proBNP is very high, if your troponin is significantly high, these are the people who are again liable to get into recurrent peripartum cardiomyopathy. I think these are the few comments which I would like to make in relation to the previous consultants who have been discussing this.
Thank you so much, sir. Manjula, madam, I have 2 questions for you. Breastfeeding in the index case, and what is your take on repeat pregnancy?
See, first, breastfeeding, yes, I would not encourage them to give breastfeeding, saying that even though we are in the developing countries where WHO gives an exception saying that we can still feed because the advantages of the milk from the mother is absolutely good. But saying that again, if there is a support system, they just help the baby coming there and feeding and then taking the baby back, and without the load of the stress and the feeding to happening to the mother, then I think we can encourage. But again, talking about the pathogenesis and the advantage of bromocriptine and cabergoline in the returning of the LV dysfunction back to normal in 40% of the cases who have been on bromocriptine, I think that makes more sense, seeing that her being the priority. So her stress, her health of not just the heart, but it is her efficiency to be able to feed the baby. Most of the time I have seen these women are so, in the sense, negative frame of mind. They don't want to even see the baby. They don't want to feed the baby. This is something which we see in the maybe the ICU psychosis or whatever happens to them. So I would definitely personally, in the few patients which we have seen, we had given the bromocriptine and the cabergoline, and we had given the top up feeds which are available right now. And the second part of it, like Raju sir said, recurrence rates are very high, but it is directly proportionate to that of the ejection fraction which will be there after the total treatment is done, maybe after 6 months. At the end of the 6 months, if the ejection fraction is more than 50-55%, and if she becomes pregnant, or she wants to become pregnant because of whatever unheard things happening to the first child or something, yes, under like Dr. Raghu said, under close supervision, she can go in for pregnancy, but we have to see that there are no nutritional deficiencies, whether or no, and salt restriction and the fluid restriction, and be under the supervision of both the cardiologist and the gynecologist. Any degree of any symptom which she complains should be taken with a extra precaution and test her accordingly. And if necessary, iatrogenic preterm delivery or even termination if necessary. But saying that if the ejection fraction is less than 35, then definitely a big no-no. It is considered as a high-risk class 4 contraindication for next pregnancy. So we would first always tell them, why do you want to go for pregnancy? But if she says that she want to go, then we have to evaluate all this and then go in for next pregnancy. And there is this one question by Dr. Praveen, which I thought I will answer, is how to differentiate between the stress cardiomyopathy and the Ppcm. So one thing is, if it is because of PRH or any stress, if we are thinking of DD of PRH, always proteinuria is the underlying thing which differentiates. If there is an associated proteinuria, definitely automatically we put it as overload afterload because of the PRH. And if there is not there, then like Sir Raju sir said or Dr. Raghu said, it is the exclusion which puts us into the Ppcm category. Or if there is an HELP syndrome, or if the creatinine is high, automatically the treatment goes in favor of PRH and getting her out of the afterload sequencing. So this is the way I would be looking at. Dr. Anu.
Ma'am, during the pregnancy, like let's say if this lady goes for second pregnancy, her LV recovered. By the way, her LV did recover. It's been about a year now.
Right.
We haven't discussed of repeat pregnancy. My first decision to her was to not plan for. But let's say if she does become pregnant, during the pregnancy, are there any Doppler markers early on that you can tell us that this patient should go for MTP because very high chance of recurrence?
See, the Doppler will not tell us about high chance of recurrence. Definitely, it will tell us if there is going to be a placenta insufficiency. If there is insufficiency, these are the patients who are supposed to be having an abnormal vascular. That's what I said. The whole hypothesis now is going more and more towards the vascular hormonal hypothesis. So they have seen that it is definitely an abnormal at the level of the vascular level, which is causing this. So if the PLGF is high at 11 to 13 weeks time when we are doing the test, and if the Doppler says there is a higher risk, I think she should be going in for termination, saying that we do have. In fact, in my practice, Dr. Raghu said 10 patients. Maybe I have also have seen around 10 to 12 patients. Second pregnancies also, not just Ppcm. So in the last 3 years, I have delivered 2 patients which are recurrent second pregnancies after the Ppcm. And they did not have any problem during pregnancy or the next pregnancy. So I think maybe it's a high degree of suspicion. And then we are looking at her very closely and doing the tests, and everything made a difference. Like I said, nutritional supplements right before they go for pregnancy. And even when they come in for pregnancy, seeing they take this L-arginine is nothing but, again, nutritional supplement. It is an, it is essential amino acid. Only thing is it acts at a different level, causing the placental hypoxia to be decreased. And most of the problems are because of the hypoxia, because of the vascular element, plus hypoxia of the maternal hypoxia leading to fetal hypoxia. And the fetal outcomes are also bad because of the hypoxia which goes with it. So I definitely look at Doppler, which will help me in termination of pregnancy or delivering a preterm delivery. Or if there is a patient going uneventfully, I would do a vaginal delivery with painless labor. And we would also look at, because we have to think of delivery pains itself causing more of overload and more of the blood output which comes after delivery, about 500 ml coming back into the circulation. So we have to look at everything. So it has to be a total multidisciplinary approach of an anesthesiologist looking at the painless labor and the cutting short of second stage of labor using vacuum or even forceps, or cesarean if the patient is really bad. But otherwise, it can be a vaginal delivery.
Thank you, ma'am. I will ask one last question to Dr. Vrinda, and then we'll take any other comments you have. So, Vrinda, we have some favorites for bromocriptine, cabergoline, some not favorites of bromocriptine, cabergoline. For the audience, I will tell you there is some data, there is some bad data about using these drugs in the cardiovascular space. Dr. Vrinda, what is your take? Because I'm sure you're using these drugs in hyperprolactinemia. What is your take on these drugs in terms of cardiovascular safety? I'm unmuting you, Dr. Vrinda.
Hi, everyone. Very informative talk. So as Dr. Anup mentioned, we use cabergoline very routinely for treating our patients with hyperprolactinemia. I think between the two drugs, like from an endocrinologist perspective, and keeping in mind that we treat hyperprolactinemia with these drugs, we prefer cabergoline. In fact, I think the use of bromocriptine has been virtually not seen recently, except if there is intolerance to cabergoline for some reason. But we prefer cabergoline because of a better efficacy profile, better safety tolerability profile. But essentially, I think the doses, there's been some concern about the use of dopamine agonist and the related valvular heart disease. But from what I have used for these many years, and from what the data supports, I think the risk of developing valvular heart disease occurs in a more cumulative dose-dependent manner. So the doses that we use for treating prolactinoma or hyperprolactinemia patients, usually the max doses that we go up to is 2 milligrams per week. And usually the risk of associated valvular heart disease is pretty low with those doses being used. I think we see it more often with doses that are used for Parkinson's treatment. Similarly, for bromocriptine, I think when you compare the data between the two drugs, the risk of valvular heart disease is more so with cabergoline compared to bromocriptine. I think we have very few reports, short studies, small number of patient studies with bromocriptine. And I think, again, the data stresses on the fact that higher doses may be associated with valvular heart disease. But for the doses that we use in treating our patients, I think the risk is very less.
Perfect. Thank you. Dr. Krishnam Raju, very quickly, I just have one direct question to you. Is there a genetic lab in Hyderabad where I can just order a STAT3 mutation for a patient? Do you know?
There are at least 3 or 4 genetic labs, though they do a lot of chromosomal studies, but I am not I can't answer that question whether they will do this or not. I can check on that. One is CCMB, Center for Cellular and Molecular Biology in Uppal area. They do extend this, one of the national institutes under Government of India. And the second is Institute of Genetics, but they are not that well equipped, so I don't really know. But third one is there is a private lab called mapmygenome.com. It's called mapmygenome. Their website is .com. So they do extensive genomic studies. They are very expensive, somewhere in the range of 25 to 30,000. They do genetic panels for hypertrophic cardiomyopathy, pulmonary arterial hypertension, coronary artery disease, sudden cardiac death, general panel, metabolic disorders. All these they do. But specifically for STAT3, I can find out because the managing director of that company is a daughter-in-law of my close friend and a classmate of mine. So I can check with her. Her name is Anuradha Acharya. I can check with her. The fourth one is fingerprinting DNA center is there, again of the Government of India, but that is a forensic lab. So I'm not sure whether they do these particular studies, but I can check.
Thank you so much, sir. Thank you. One question that came up is how long to continue the cardiac remodeling drugs after the recovery of LV dysfunction? And Dr. Prithvi, truly speaking, I'll just answer this question for the sake of time, because we really don't have good data about how long to continue. And this whole concept of heart failure with recovered ejection fraction, particularly in the post-partum setting, that science is all out. I typically continue for a minimum of 6 months, and then I check their BNP levels. If they're elevated, I continue till BNP is elevated. And if they are planning for a repeat pregnancy, then the medicine does not stop. That's what I do. There is no science behind it. There is no guideline behind it. We are 5 minutes out. I would invite anybody else, if they have any other comments, questions, or thoughts, anything, maybe for the next 2-3 minutes, we can continue our discussion. If you have any other questions, otherwise we'll call it a day. Anyone else has any other thoughts? You can unmute yourself and share your thoughts. Okay, if not, then let us try and close this, because I think this is a topic where we can just continue on and on. So if nobody has any precise question or comments, maybe we'll start closing this.
I would like to, Anup, I would like to just give one sentence comment.
Sir, please.
Yeah. So when we are in a tight situation where there is a really very critically ill pregnant woman, then we have other options available now, unlike say 10 years back. Like for example, you may have a intra-aortic balloon, you may have an LVAD, LV assist device, or there are centers where they have even done a cardiac transplant. Now you know that Sir Magdi Yaqub from England. Sir Magdi Yaqub is an Egyptian surgeon, but works in England. He has, I was listening to his lecture in ACC few years back. He showed a excellent demonstration of explantation of implanted LVAD in cardiomyopathy, not postpartum, but cardiomyopathy, dilated cardiomyopathy. So he had shown normalization of the cardiomyocytes and complete normalcy of the myocardium after explantation. So he then brought out a hypothesis that there is a group of patients in dilated cardiomyopathy, probably also postpartum cardiomyopathy, that is my addition, that if you can bring them out of the pregnancy and deliver them safely and have an LVAD, there may be complete recovery of the myocardium. As you are aware, LVAD is an invasive surgical procedure, but now there is hope. There are trials that are going on in the laboratory on the bench. There is a percutaneous LVAD. So when the percutaneous LVAD comes, it may be possible that we might think of using it in this woman with peripartum cardiomyopathy and take it off later on once the myocardium becomes normal. That is another comment which I wanted to make. Thank you.
Perfect, sir. Thank you so much. I again invite if anybody has any other questions or comments. Dr. Manjula, we had you on this session, which we thought would be good for us for the first time. Could you share your comments about the session, not the topic, but the session as a general, how we can make it better?
It actually has made me so nostalgic about my early morning sessions, which we used to have in care, 8 o'clock sharp. We used to have all these academics going on, which I really, truly miss. And this has actually given me an opportunity to join all my sirs and everybody. And I think I would like to be involved regularly in these sessions. I thank Dr. Anup and Praveen for involving me.
Thank you so much, ma'am. Praneeth, your closing comments for the session?
Yeah, so thank you all. Thank you, our guests today, for sharing their knowledge and educating us. So I think it still is a lot of gray area in management of peripartum cardiomyopathy. Again, at the end of the talk, I still don't know when to give and what to give. Only thing probably which I have known is some prevention in the aspect of giving arginine, selenium, etc. I am glad to know these things, but when it comes as a peripartum cardiomyopathy, probably only heart failure management and nothing more than that, and probably some expert advice when needed. This is what I could take from this session today.
Thank you, Praneeth. Thanks a lot. I thank all the participants. I think that the key ideas that we got from the session, first is of course related to heart failure therapy. The medication choices that we have, there certainly is some difference in practice patterns in terms of bromocriptine and cabergoline. Probably some of us have low threshold to start it, some of us have high threshold to start it, and so is in relation to breastfeeding. I'll share the experience for this particular patient, where I wrote for the patient that it is okay to breastfeed. Our gynecologist for the session, appropriately, as what Dr. Manjula said, they wrote against breastfeeding, and not for the obstetrics reason, but primarily for the cardiomyopathy reason. So I think that some of the difference in opinion or difference in patterns comes because the science is not clear yet. As Dr. Manjula pointed out, that even the pathophysiologic understanding is shifting from microRNA based to more of a double hit theory, where some person who is already at risk with some sort of cardiomyopathic risk factor, and now pregnancy becomes their second hit, just like for a lot of other cardiomyopathy, viral infection or whatnot becomes their second hit. So it's an evolving field. Certainly we will know much more. Genetics is a important determinant on this. Patient counseling is very important, and anticoagulation, which I wanted to put up a specific topic of anticoagulation, but I think for the sake of time, we'll keep it at this. So I thank all of you for joining, and if you have any input for the session in terms of how we can make it better or any topics that we should involve, please let me know. We are very receptive for this. This is the 6th month that we are doing it, and we are hoping that we are going to continue doing this. It's 1 hour a week, doesn't take much of our time, And being an audio, we are really not committed to anything. So we hope to see you again, and we hope to hear feedback from you. Good night, guys, and thank you again for joining.